Welcome to the 6th webinar in the MGHS Institute Interprofessional Webinar Series. My name is Pauline Lesage. I am a physician educator at the Institute for Innovation in Palliative Care. The topic of today will be prognostication, but second part. So as you remember, maybe 2 weeks ago, for the one of you who were following this webinar, we talked about prognostication in cancer patients. Today, we are going to talk about prognostication in chronic illnesses, various types of illnesses. So the plan of today is the following. First of all, we'll do a little summary of the lecture number 1 for the one who did not attend, or in just refreshing your memory about what was said. And then we are going to talk about the disease-specific indicator and also the hospice referral criteria. So we are going to talk about those various diseases: congestive heart failure, chronic pulmonary disease, dementia, renal disease, liver disease, HIV/AIDS, and cerebrovascular disease. For each one, we are going to talk about a few tools to prognosticate, but also do the counterpart in the hospice referral criteria. Before we go to that, let me read you something, and I was very pleased to find a nice quotation in the recent book of Dr. Eric Cassel about the nature of being a clinician. And just to let you know that prognostication has been something all along, and there's nothing new under the sun, since that even in the Hippocratic era, being a good prognostication physician was one of the most esteemed quality for a physician. So let me just tell you how Dr. Cassel is defining prognostication. Prognostication is not some kind of magical ability to see into the future. Its basis is a solid knowledge of medical science, pathophysiology, and disease, careful observation, and knowledge of how sickness and sick patients change from day to day, week to week, month to month, and how that comes about. So meaning what is said here is that to be a good prognostication physician, you have to know the disease. And this will be particularly true today when we see all this variety of diseases. If you know the course of the illness, the pathophysiology, or whatever you need to know to feel comfortable with the disease, you will be much easier, or it will be easier for you to prognosticate eventually. Also, let's keep in mind that the further into the future we want to prognosticate, like months, a year, the harder it becomes and the greater the uncertainty. This being said, let's just summarize a little bit what we said 2 weeks ago. We remember what we said about the why prognostication, and I'm sure that by now you certainly do understand that patients, like as well as physicians, needs to know where we are going. It's, I would say, an analogy. If you take a road and you want to go to a certain destination, well, you will use a GPS, or you will use a map, or you need to know a little bit where you are going. And this is part of living, I think, and it's just not proper to what we do in medicine, but for every disease, for everything, even in an acute setting, which is probably less striking, but prognostication is always omnipresent in the sense that we need to know where we are going, what is going to happen. We are not good at doing that. We said that last week, that physicians are inaccurate in 30–40% of the cases, and usually we are very optimistic, which is good, but can also have a negative effect of being too optimism. Many death curves, we are going to review that very rapidly today before we talk about the main part of this talk, in the sense that according to the various curves, it can be more, and some will present much more difficulty than others. Also, on the trajectory of illness, you remember the slides about the two inverted triangles, the one with disease-modifying therapy and the one with palliative care. And they are not totally estranged one another, They can be sometimes in collaboration, in the sense that we can have a patient who is in palliative care and will need temporarily some disease-modifying therapy, like going to receive a blood transfusion, going to get some intensive IV therapy, antibiotherapy, and so therefore we should not take this differentiation too strong, in a sense that they are not impermeable to one another, but they are really in communication at times. Prognostication is not an exact tool, we said that, but it's not neither just a little something that we have and it's a bluff, or we don't know what we are doing. There's more to it. There's a little bit of science to that, and this is why those two sessions are about, to sort of learn a little bit to become better prognosticator. So in this trajectory, just to refreshing your memory here, you can see that the two curves that we are concerned about today will be the end organ failure curve and the dementia curve. And as you can see, they are bumpy, and therefore that is to say that our prognostication may be bumpy at times too. In prognostication, not only we need to know the disease-specific indicators for each disease, but also the non-disease indicators, which sometimes will be very important in influencing the curve of prognostication. And we will see how this is going to play in the next few slides. The non-disease-specific indicators are all the one that has to do with the functional status. And remember, we spent some time on talking about the ADL, the functional capacity of the patient, which can be measured by different scales, the Karnofsky being one of them, the PPS is another one, the ECOG, and whatever you like to use, but try to adopt one of them, and really you will see how it can be useful with time. There's not a day that we don't use those Karnofsky scale in order to, it's a very broad evaluation, but that's a start. Now, the non-specific condition indicating of serious illness, recurrent serious infection. We know very well that a patient with COPD who monthly go for pneumonia, well, eventually may recover from the pneumonia, but at one point the recovery will be much more difficult. So that will be a bump on the road, but it will still indicate that with every acute episode the curve is going downwards. Evidence of severe malnourishment, so we talk about the albumin, how important that is, the weight loss, and so on and so forth. The pressure also is an indicator that you are immobilized, and so your Karnofsky is therefore very low. And the multiple comorbidities, again, you will see how it plays a role today in those various diseases. The more comorbidities you do have, the worse your prognostic becomes. Let's now go to the course of this session, and let's talk about different diseases. The first one, I pick up the one that I think that we are more concerned about, that we see more often, that are common in the clientele of hospice and palliative care patients. So the first one will be the CHF. And to me, this is one of the most challenging in prognostication because, as you know, CHF and cardiac have evolved a lot over the years. We have new drugs, new techniques, new device, also AICD, and so on and so forth, that modify the disease, the course, and therefore it becomes more difficult. Difficult doesn't mean impossible, and so this is why we have to look into. So, as you know, following a new diagnosis of chronic heart failure, 40% will survive less than a year. So it's not a good disease. But 1 year mortality can vary from 5 to 75. And I guess that you all know that when we see an interval of such wide interval, this is really means that we don't know, and probably everything goes. So 3 examples. Let's look about what we have as far as tool for the CHF. And there's many on the market, and I cannot talk about all of that, obviously. And I will pick up one of those, which will be the effect cohort study. In that study, effect cohort study, which was on about 4,000 patients, the predictors of mortality that was significant for the authors of this study were the age, the respiratory rate, the systolic blood pressure, the BUN, the sodium, the hemoglobin, and the comorbidities. So what they do, and it's always more or less the same principle, what the researchers doing is to first identify the predictors, second to score them, and then study that in their cohort. And so you can see again on the left-hand side those various variables, and then you see the points that are given to either the 30-day score or the 1-year score. And then you score that, and then depending on the score, you will have a X amount of mortality or not. Please note that, again, when you use a tool, whatever the tool that you are using, you have to know what you are measuring. Is that a 30-day prognostic, or is that a year? So it makes a big difference. And as I said at the beginning, the future, the predictability for the longer term, it's much more difficult to do, and because there's much more uncertainty. So this is just the slides showing the results of this mortality for the 30 days versus the 1 year, and you can see that the high scoring, meaning 150 more points, well, of course, the death rate is higher. Let me tell you that this is not working all the time, and I had an example many years ago, 6, 7 years ago, a patient who came to us as hospice, had the GIP on the unit, and CHF, advanced CHF, he had an ICD, and he was not really doing well in disease-modifying therapy medicine, and so we accepted him in hospice. And surprisingly, with days going on, patients was doing better, to a point that we said, and we previously turned the AICD when he came in because we thought that that was the time. That's a real discussion that we can have, but that's not for today. And this patient did good. He did so well that eventually we said, well, maybe we should not have turned this off, this device. And second, maybe it's not that hospice appropriate at this point in time. And sure enough, a few weeks later, this patient was decertified and sent to his cardiologist, make it home, and survived multiple months after that. And eventually, I did not follow because it was no more in hospice. But I think that we need to be able to be in a system, play with the two systems in the sense that don't be so dogmatic that when patient is diagnosed as such, there's no way that we can move around. So again, especially for those diseases who can be sometimes tricky. So CHF hospice guideline, the hospice guideline are the following. New York class 4 for cardiac disease, so meaning serious cardiac symptoms at rest, but also some other relevant findings like an EF of less than 20%, arrhythmia, pulmonary edema, and comorbidities. And oftentimes we will have patients who will come in hospice who will not be necessarily the class 4, but will be class 2, 3, but will have so many comorbidities, which is not unlikely, as you know, disease with age tend to accumulate, and it's not unusual to have the COPD plus the CHF and some other condition together. Non-cancer lung disease. Lung disease, COPD, emphysema, or interstitial lung disease also do have a rocky course, but maybe not as much as CHF can have. But again, it has a lot of symptom burden. And it is important to know where we are at in the illness trajectory, because there's lung transplantation. There's also the discussion about what's about if you come sicker, will we use the BiPAP, will we do, will we intubate, to be preventive, to see things happening before we get there. And so that is important to know. Prognostic, again, multiple tool. We are going to talk about the BODE score. There's a score also for prognosis in exacerbation. Example, patients who will go to the MICU for an acute exacerbation. So there's a DCAF score. I'm not going to talk about that today, but there is such a thing now. And needless to say that because we have more and more information about those diseases, we see more and more of them, patient and population is aging, therefore live longer, therefore we see more and more. We will become more knowledgeable, and we will have tools that will be slightly, or even at times much more refined than we used to have for various diseases. So this COPD and scoring system for COPD, the BODE score, is the following. Again, the variable is the FEV1, the dyspnea, the BMI, and the also the force and the exercise capacity. So again, scoring system 1, 2, and 3. The higher the scoring, it's always the worst prognosis usually. And how it reads, the results, how it reads, it's following, is as you can see with the points, the higher the points, the most mortality. And again, read, and it's mortality at 4 years and not necessarily at a month. So again, when you use a scoring system, let's make sure that it's applicable. The hospice guidelines are breathlessness, usually oxygen dependent, and with some finding. It's good to have some of those findings, but I must say that oftentimes we do not have necessarily the latest blood gas or the FEV1. We don't always have that. Nevertheless, we can still make a referral because those patients accumulate comorbidities, complication, non-specific condition. And don't forget that in this class of patient example, multiple hospitalization for pneumonia every 2 months, 4 or 5 a year, and so on and so forth is also an indicator that time is running backwards. Dementia is it's a topic that we cannot avoid. We all know that the population is aging significantly. In 2030, I think that we will have about 10 millions, 2030, about 10 millions of 85 years old and over, and which means that we'll have probably 25% of those who will, unfortunately, will have dementia. So 1 out of 4. So that's a lot by the millions, and so we better be prepared to know how to deal with that. And dementia is a difficult one in the sense that, again, this is a bumpy curve. It is also the fact that there are decisions along the road that needs to be made. One is the PEG, no PEG, and all this discussion about feeding. That's still a discussion that's going on. And the fact that it has to do also with food, the notion of starving. So that will make a very important impact on decision making. Therefore, if we know a little bit more where we are at and what to expect, we may be able to make a better decision. So we know, example, that the 6 months mortality in patients with pneumonia and is really bad. It's a bad sign. An infection, a febrile episode, or eating problem is really the sign that is really there's a big decline that is coming. So difficulty to prognosticate in dementia, it is, although we had become a little bit more astute for that, and it seems that, and I will talk to you now about the FAST scale as well as the ADAPT tool, and you will see that it's a little bit clearer, although it remains still a difficult thing. So there's no such a thing, the ADAPT tool being a little bit better maybe than the FAST scale, but then again sensitivity 27%, the FAST scale is about in the 20-25%. It's really, I would say, a great an indicator. This is the FAST scale that I'm sure most of you know already, and it started to be really significant when the patient has a FAST of 7A, meaning that the patient is has difficulty finding words. It's gibberish. It does not make sense what he's saying. Still confused, but really lose the ability of language. At that time, he already had lost the ability of dressing up, of eating by himself, and so on. So I think that this is a place at 7A that is very significant, because from then on it will be just a very downward curve. The ADAPT tool, which is a bit newer, again the numbers studied in the 200,000 and so on and so forth, and the same principle always, the characteristic or the variables on one side, then the scoring system, the add-on on the point, and then eventually the results. And if you look at the results here, sorry for the slides maybe, but just trust me, example with the ADAPT score, if we have a scoring system more than 28, therefore you have 100 mortality at 6 months and obviously at 12 months. So I think that we can combine both. We can use this one and that one and eventually get to better understanding. Let me tell you though, and just again to give you an example how difficult it can be, I will always remember this patient who came to us, a severely demented lady who was at the point of not being able to eat by herself, contracted in bed with some decubitus ulcer. And for a religious reason, the two sons, who were the healthcare proxy at this point, after a long discussion about PEG, no PEG, decided that they could not go along without not putting a PEG in. And the argument was saying, well, you know, we have to do that. So we put a PEG on, and 3 years down the road, at that time I was not, I must say, let me interject here and say, well, maybe that was not the best decision, you know how it goes with the dementia and the PEG feeding. But I said, okay, let's do it. And 3 years later, they came to me, the same patients, which was obviously at this point much worse with more decubitus ulcer. And at that point, they said, well, doctor, we tried it. We did that. It's time to stop this feeding. Patients was really cachectic and severely, you know, demented. And my reflection was at the time that, just to open and close parentheses, if we did not have put the PEG into this woman, she would have died with 4 to 6 weeks. So we gave her more years. Obviously, with her dementia, she did not benefit maybe from that. The son did that. So again, pros and cons, what do you put in the balance to make a decision? It's not always obvious. So dimension guidelines for hospice is, again, as I was mentioning before, the FAST-7, inability to eat, and most of the time there's always some comorbidities because dementia comes usually in older people, so you already have multiple other complications. End-stage renal disease, we see more and more. It's not unusual to see older people also receiving hemodialysis for a long period of time, and then they develop a comorbidity, a cancer, CHF or something else, and then we start discussion again, where shall we go, where we are at, and shall we stop or not the hemodialysis. So again, there are tools. The Charlson is one of those in the comorbidity index, giving points to different variables, adding on, and giving you an annual mortality. So you can see that one of the worst combinations that somebody can have will be to be on hemodialysis and out of a sudden develop a cancer or HIV/AIDS, because at that point the annual mortality will be more than 50%. So again, it's an indicator, and it can be very useful because if patients and family were not really ready to stop hemodialysis per se, because patients were doing well, when you develop another disease, we need to be able to put that in another setting and say, well, things are not looking exactly the same. For end-stage renal disease, for hospice criteria, patients do not have to give up hemodialysis if it's not related to the diagnosis, to the hospice diagnosis. An example would be a patient who has a cancer and wants to continue to have hemodialysis. So it seems a little bit counterproductive at times, because eventually we'll have to give up hemodialysis, since the cancer will be the disease that will bring upon an ending to the life of the patient, but it's still a feasibility. So you have that creatinine, BUN high, and most of the time there's always some comorbidities. End-stage liver disease, and I see that time is passing by. Let me just again, and it's the same, and as you know, we see a lot of cirrhosis. Patients who now survive a little bit longer will or will not develop a cancer of the liver. And the problematic here is that some of them will be on transplant list, and sometimes team will be reluctant to refer, because we don't know if he is really at the time when he will benefit, when the patient will benefit from hospice or palliative care, or simply should we pursue still the transplant. So there's a few, again, tools there that are existing that we use regularly. Again, a case will refer to me and from another hospital recently, and they were using the Child-Pugh classification. And it's pretty good for prognostication if you combine that with some of the tests as well. So without going into the details, you see here, depending on which class you are, how is your survival or not. Again, another which will be the MELD score, which is often used also, a MELD score of 20. Patients this morning, MELD score of 58. So obviously, you know, it does not really lie at that point in time. We have good data showing that survival will be not so good. End-stage liver disease, hospice guideline referrals, here they are. So INR higher than 1.5, and albumin low, ascites, of course, hepatic encephalopathy, and comorbidities and dementia, and so on. AIDS is a very, very interesting disease because it changed significantly. For the one of us who are a little bit older, we saw that it was an acute disease. In the 80s, people were dying in 6 months to a year, and now it's a chronic disease, as we know, 20 years and over. So, so are the criteria also that change with time and help us to prognosticate. It's still, there's not that many written about AIDS and prognostication because most of people would like to remain on heart therapy till the end. This changed a little bit, and this has been a criteria that has been accepted recently at changing the prognostic of the patient being on heart or not being on heart. Also the Karnofsky, the age factor, the opportunistic infection, and the untreatable complication. So age again, change, and this is something that I would like to mention for all those diseases, since we are accumulating much more information now on each of them, having more studies, will be able to do better with time. And also we need to keep in mind that they are changing. What was good maybe 10 years ago may not be so good because we have a little bit more information down the road. And cerebrovascular accident, which is a disease that we'll see more and more because population, as we mentioned, is aging, and this is a disease of the elderly population. So we have, I would say, two phases. There's the phase, the immediate phase. Patients, it's obvious because the disease is so bad, the hemorrhage or the emboli is so large that the patient is not able to recuperate, is comatose and so on, so therefore it can be an automatic referral just after a few days of the stroke. But also there is those patients on stroke who will recuperate somewhat, who will have a peg feeding and so on, and then eventually will not do well, will develop all kind of complication, infection, decubitus and so on, and then will come back to a late referral to hospice. Let me conclude here because, again, we went a little bit fast. As I said, it is a lot to assimilate, but I think the good thing about that and the way I see that is that there's something there to help us, to guide us, and say, well, I'm looking at this and that, and without telling you that you have 3 days, 6 days, 2 months, which is something we should never say. It should always be a range, an interval, is helping us at least to see in the future and help us to guide our patients also in making their own decisions. So it's a central element in what we do as clinicians in the decision making. And when we are going to have a session on consent, we also talk about it's part of truth telling, don't forget, and I think that's it's one of the things that we should be good at doing. And in chronic non-cancer illness, it is difficult because of the bumpy curve, but there is something, there's some help around the corner, and I think that we should be able to look into that. Let's talk about a question, and I'm sure I do see already some that are there on the board. 1.3 years median prognosis for all dementia regardless of scale 2 results. I don't know if there's any tool that's so specific to give you a precise time. And if there is something that I can say about this prognostication, is try to avoid to have 2 exact numbers, because this is where I think we make mistake, and this is why many physicians or clinicians are really reluctant to use prognostication, because they say, well, how can we be so sure? No, we are not so sure. It is full of uncertainty, we realize that. And I think that the only thing that we can say is it is an approximation, it is an average, it is an interval of time, and just avoid those really exact number. One of the questions, I'm not sure I'm reading well, the question was that for the dementia, regardless of the stage, no, the dimension, for the dementia, the prognostication is based to the staging. When we talk about the staging and the short limit of time, is that the worse you are on the FAST score or on the ADEPT score, as we mentioned, the worse the time frame is. As we know, dementia, and this is why it makes so difficult, and especially for the patients and family to understand, because it's a disease that can go on for 10 and more years. And so it's long, and it is hard to understand it at one point. It is the final point. That is nothing much to gain because it is so long. And as I mentioned and said initially, that the further we want to prognosticate in the future, the harder it is and the most uncertainty that there is. With end stage, let me see here, any specific guidelines for traumatic or anoxic brain injury? There is, and maybe I passed a little bit fast on the CVA and all of that. Usually it seems to be related, and this coincident that I did not, let me go back to some of that, I did not mention that, but it seems to be related to the larger the effect in the brain, the larger the infarct or the volume of a bleeding is, the worse. If 40% of your brain is gone, that is probably no. There are some also more precise if you remain comatose for 3 days or more, and so on and so forth. So the time frame can be, and sometimes it's difficult, sometimes we are in between. There's a few patients open eyes or do a few things that we say, well, where we are going with that. So we'll need, it's a little bit tricky, and we will need probably a very good expertise in neurology to say that. We are still struggling, but certainly one of the major things is that the more comatose, or the larger the infarct is in the brain of a patient, the worse the prognostic will be. And if the patients cannot maintain the hydration, and we are not planning to put a peg, because that will be also a lot of the decision will ended up on this. We are not planning to have, my mother never wanted to be on artificial means of whatsoever. And if we know for sure that the patient is not going to recuperate, the minute we know that after having spent some tests with the speech and swallow, the minute we know that, and we know that the patient did not want to be fed artificially, so then it becomes a different category of patient who will obviously benefit of hospice treatment, hospice services meaning. I would like to think, so some of the reference article, maybe they were not on that, but they will be certainly available on the slides, because they were here, some of them. And for the one of you who are asking, they're one of the most versed into the prognostication is really probably Chris Takis. There's a book who was written many years ago, but there's always some new articles that are published on that. And as I said, it is important to be updated on that, because it keeps changing. We have new things. So for the one of you who are asking, and so here are some of the references that you were mentioning. I would like to conclude, maybe it's not one of the questions here, but it was mentioned last 2 weeks ago, the multidisciplinary involvement in prognostication. And I think it is important in 2 ways. One of the first way is that it is not, prognostication is not just the clinician who comes and say, well, I think this is it. It's usually done by the physician who has the expertise, or the clinician to do so. But then what will come is 2 things that the team can be very useful. First will be the support, because once the patient will have some information about that, he may depress, he may, or the contrary, maybe say, oh, at last I know, and I know where I'm going. But you will need some support. You may need to talk also to some people, which maybe was not finding the right person in the physician to discuss that. They would like to discuss more on another level. So he would like some support and some understanding, or to be here just about his story and so on. So the team can provide the support. The team also is important that knows where we stand. If we don't discuss the prognostic in the team, IDTs, and the social worker, or the nurse, or people who are not the clinician or the chaplain, for instance, are trying to maintain hope of the patient and then will say, oh, well, this is just a number, or say different things, it may put the patients in a very, very uncomfortable position, not knowing where we stand. One is saying that, but the other one is saying that. So once we establish a certain course of the illness, trajectory of the illness, it will be important to share that in the team and say, well, you may want to encourage the patient, but you are not going to change the facts. The facts are that the disease is not so good after all, and then eventually there will be some endings here. Let me mention and let me cite again, I must say that I'm so happy that Dr. Rebecca mentioned or wrote this new book because it's quite enhancing. We have a sense that sometimes that the clinical expertise of clinician is almost gone to the point that it's mainly tests that we are doing. But I'm glad to discover that even nowadays we still talk about that. Let me say that that is, and as conclusion on prognostication, that is what it is and nothing less. It makes huge demands on clinicians for the patient's family, and other caregivers. Because of continual careful observation and own abilities to correctly predict what is about to happen, clinicians have the opportunity to prepare not only their patients but themselves for what is coming, no matter how awful it may be. So I think this is just a little something, and say, well, there's a place for prognostication in what we do. I would like to thank you all for the attendance of this webinar, and that was the last one of this series on prognostication. The next topic will be on December the 3rd by Dr. Portnoy, and it will be treating of drug therapy for neuropathic pain in the medically ill. Please do not forget to fill up your evaluation, and hopefully we'll see you in the next presentation. Thank you.